My name is Alex McFedrin. We're very happy to have you join us today. I work at WHO headquarters out of Geneva with the EPI-WIN team. And this is a webinar brought to you by the WHO Faith Network. It's the first of a series of webinars hosted by the Resources Working Group, which is a working group looking at the different available resources by partners in the faith community that can be applied to different health emergencies. So today we're looking at language and in a broad sense, and we have a number of great speakers with us today. We have Paul Frank from SIL International, Mark Mutai from World Vision International, Catherine Young from SIL International, Sophia and Nthenda from the Women of Faith Peacebuilding Network, and PAC in Malawi, and perhaps Robert will join her later on. So we're very happy to have you with us today, and we're apologies for any delay. We're looking forward to this great discussion. We're going to have a round of questions and panel, and then we're going to open up for Q&A. So we do have 90 minutes, or now a little bit less, but there's plenty of time for Q&A, and we do hope you can use the chat function to ask your questions, or sorry, not the chat function, the Q&A function, and we'll go to that section after the presentations. If you'd like to hear this webinar in French, it is available. If you click at the bottom of your screen, there is a French translation, so you can move to that channel as well. This is being shared live stream to YouTube, so we're happy to have you look at it later or share it with colleagues, or if you have to drop off to finish up later on. These slides will also be shared with anyone who signed up through the EPI-WIN newsletter, received this, and we're happy to share them with you afterwards and other information. So I'm going to hand it over to Paul Frank shortly. If there's any questions or comments, please put them in the Q&A or in the chat, and we'll be happy to share with you more as we go forward. Over to you, Paul.
Sorry, Alex, to just interrupt. We see presenter mode, so if you want to just...
No, this whole time. Okay, great. Thanks.
There's a button up there that says use slideshow. Is that the one you want?
I thought I was there the whole time.
There you go.
Great.
Good morning, everyone, and welcome to the webinar today. Thank you for joining us. We all know how important communication is in health. It's critical. And today we're going to hear from well, I guess it's going to be three panelists who are going to share tools from their organization that they develop for addressing issues of language, culture, beliefs, and interactions within society. The panelist organizations pivoted during COVID-19 to reach those who are most vulnerable. So we're going to be learning from their experience and considering how to better prepare ourselves for future challenges. Now, just briefly, our panelists today are Mark Mutai, who is the Senior Program Effectiveness Manager for World Vision Sierra Leone. Mark provides leadership to design, monitoring, evaluation, research, and learning in Sierra Leone. He's going to be presenting on barrier analysis, which is a rapid assessment tool used to identify behavioral determinants associated with particular behaviors such as vaccine acceptance. And this tool is used to develop more effective behavior change messages and activities. Secondly, we're going to be hearing from Catherine Young, and she is the Director of Global Language and Development Services for SIL International. She's going to speak to us on the use of local languages in order to support comprehension and application of information in health, and featuring also SIL's tool, Bloom, book creation software. Then we'll hear from Sophia Nthenda, who is the Deputy Executive Director of the Malawi Public Affairs Committee, which is the Religions for Peace affiliate in Malawi. She is going to be sharing about the Mind and Heart Dialogue, an approach that uses experiential learning methods to invite faith actors into a co-creation space using social behavior change strategies. And this combines scriptural teachings with technical interventions and evidence to catalyze positive behavioral outcomes for children. And this is an approach that was developed jointly between UNICEF, Religions for Peace, and the Joint Learning Initiative on Faith and Local Communities. Our first speaker is going to be Catherine Young. So welcome, Catherine. and I'd invite you to tell us about the tools and resources and perspectives that SIL developed during the COVID pandemic to help address the use of local languages for effective health communication with non-dominant language communities.
Thank you, Paul. Can I just check that I'm being well heard? We good?
Yeah.
Thank you. Yes, thank you for that introduction, Paul. As you said, one of the specific areas of focus of SIL International is to support local language communities in order that they are able to access education, in order that they are able to access information, and that they are able to use their own languages, the languages that they use in daily life, to access and to support their own education and development initiatives. At the start of the COVID-19 pandemic, some SIL researchers used data from the Ethnologue, which is a catalogue of the languages of the world, which describes the ways in which the languages of the world are used and the locations in which these languages are used. SIL researchers analyze the data from the Ethnologue and the global knowledge that SIL brings to the local language situation, and estimated that there was probably around about 30% of the world's population that did not have access to basic health care information in the languages that they speak and understand the best. And this was a critical piece of information that supported the direction that SIL took in responding to the COVID-19 pandemic. When we think of the use of local languages in supporting communities in crisis, in a crisis such as a global pandemic, we want to ensure that the information that is received is clear. The information that is received should be natural, it should be accurate, and it should be in a form that is acceptable to all that receive that information. Clear, accurate, natural, and acceptable are foundational approaches to the development of local language materials for any community, but primarily for local language communities that are often marginalized in the use of their languages in development activities. And as Paul mentioned earlier, primary concerns are issues like comprehension and the ability to apply that information to the issues at hand. It's a respectful approach, an approach which puts the recipient of the information at the center of the process, rather than the creation of material being the primary activity. At the beginning of the global pandemic, SIL International and SIL Lead, a subsidiary organization of SIL International, recognized that a tool that was already existing, which is called Bloom, or Bloom Library, the Bloom platform, if you will, had already been used extensively for elementary school curriculum development, for developing materials for elementary schools, particularly in multilingual contexts, and had been used for community literacy and development situations. But early in the pandemic, we realized that the opportunity to use Bloom as a tool to support local communities to develop materials to respond to primary healthcare issues was, this was what we really needed. While SIL is not a health specialist organisation, and I do want to emphasise that, when activities related to primary healthcare can be designed and delivered in local languages and supportive resources developed, those resources and those interventions increase in quality and have the potential to enable individuals and communities to flourish. So I'd just like to spend a few moments talking about this graphic that you have on the screen and describing why we felt the Bloom platform was particularly helpful in developing resources that were particularly for local language communities. Because using Bloom, you can go beyond simple paper books. On your screen on the left, you can see that the Bloom editor can be used to create paper books. But you can easily create talking books, comic books, sign language books, and I'll say more about that later in this presentation, and books with interactive activities. Bloom enables the publication of these materials as ebooks, books that can be uploaded onto websites, as standalone mobile apps. And during the COVID-19 pandemic, we found that the development of materials using the Bloom platform enabled rapid sharing of materials through the WhatsApp app and through other means where small videos could be shared rapidly. Bloom is not just about being able to easily translate existing books into new languages, but the Bloom editor uses where creators can use an offline editor to create unique materials responding to the local situation. And as I said before, naturalness and acceptability is so important when working with local language communities. And so often the creation of materials where language speakers are responding to their own context and their own environment is so very important. Cultures and languages have various patterns of communicating and telling stories. And so by using these familiar patterns of communication, local language communities were able to help both new readers who were not highly fluent even in their own language, to make sense of the text and to enjoy and to be able to apply materials that were created. Each community had its own specific areas of challenge within the COVID-19 pandemic, particularly perhaps access to water, access to soap for washing hands, specific ways in which transmission took place. And so because the Bloom editor enabled easy sharing of information and easy creation of materials, the materials that were created could be natural, could be acceptable, and could respond to the needs of the community. Communities often have important local knowledge, and using the Bloom editor and ensuring that materials were uploaded into the Bloom library meant that materials could then be adapted as more information was discovered about the COVID-19 pandemic. And we found that materials that were created in March and April 2020 had to be updated, had to respond to the new information that was discovered about transmission and treatment of COVID-19. And so the Bloom platform, as a mechanism for creating materials for local language communities in the languages that people understand the best, materials that were clear, accurate, natural, and acceptable to the community, was found to be flexible, was found to be, it was an excellent platform to involve community in creating materials for themselves. And I think I'm going to have an opportunity later to share about some materials that were created and to talk about some of the specific materials that were created for specific audiences, specifically sign language, users of sign languages. So thank you very much.
Thank you, Catherine. We do look forward to hearing a few more details from you in a few minutes. Next, we'd like to hear from Mark Mutai, as he is going to speak to us about barrier analysis. Now, Mark, many of us have heard about barrier analysis and maybe have some familiarity, but perhaps not everyone. Could you give us a brief overview of that methodology?
Thank you so much, Paul, and good afternoon from Sierra Leone, West Africa. The barrier analysis tool is a rapid assessment tool that is used to identify behavioral determinants which are associated to a particular behavior. And the reason why we normally carry out barrier analysis is to be able to develop evidence-based messaging, as well as activities that will be able to address those behaviors or determinants that you will have identified in barrier analysis. World Vision has used barrier analysis over time. Initially, it was used in child survival programs, as well as in reproductive health. But over time, we started using it in public health emergencies. We've used it in Ebola response, as well as in COVID-19 response. And one unique thing about barrier analysis is that it is based on the L-belief model, as well as the theory of reasoned action. And in barrier analysis, it is quite a low-cost methodology. It's quite a low-cost tool that is very simple to be able to use, which makes it quite relevant for public health emergencies. The sample size for a barrier analysis study is 45 people who are doing a particular behavior and 45 people who are not doing a particular behavior. So the logic here is to compare people who are doing a particular behavior and those that are not doing. And from that, you can be able to identify those determinants that are influencing people from taking a particular behavior. For example, using a mask in COVID-19, as well as using or taking a COVID-19 vaccine. In barrier analysis, there are quite a number of determinants, behavioral determinants that we normally explore, about 13 in number. One is perceived severity. And in perceived severity, what makes an individual to practice a particular behavior is dependent on how that individual perceives the severity of the impact of that particular or failure to do that particular behavior. An example is COVID-19 vaccine. Do I think that if I don't take a COVID-19 vaccine and I get COVID, it will be severe and I'm likely to be hospitalized, or it might not be severe? And that in a way will determine how I respond or which kind of behavior I'm likely to adopt. Another determinant is perceived action efficacy or self-efficacy. Do I have the skills? Do I have the knowledge to be able to carry out that particular behavior? And the logic here is that if I have the skills and the knowledge to be able to carry out this particular behavior, then I'm more likely to take it up. I'm more likely to practice that particular behavior. Access in terms of geography as another determinant, and also in terms of language, cultural issues, and gender. That if, for example, in the COVID-19 vaccines, is it available in an health facility close to me? Or I have to travel quite a long distance to be able to access that particular vaccine? Are there any cultural values associated to maybe accessing that particular vaccine? Are there any gender-related issues that may be influencing how I respond or how I take up that particular behavior? Other determinants are perceived divine will, that the people or my faith, does it approve of me taking that particular behavior or practicing that particular behavior or not. And the case of COVID-19, for example, we know that some people said, if I take vaccine, my pastor or my sheikh will not approve of me taking that particular vaccine. And so we get to understand what are these determinants around divine will that are likely to influence an individual from practicing a behavior or not. Another one is social norms, or the people around an individual who are likely to influence him or her to be able to take a particular behavior. It could be a parent, it could be maybe a wife, grandmother, it could be maybe a relative, it could be maybe your political leader who will say, you need to take this. Will they approve of me taking that particular behavior? And that in a way will determine whether I'm going to take it or to practice that behavior or not. Another one is perceived positive consequences, that if I take this particular behavior, if I practice, in the case of COVID-19 vaccines, if I access the vaccine, what are the advantages to me? And if I don't, or perceived negative consequences, if I take, what negative consequences will happen to me? And this case is about the side effects. If somebody feels that if I take these vaccines, then I will have maybe side effects, then that person is not likely to take that particular vaccine or to practice any particular behavior that may bring negative consequences. And quite a number of other determinants that are often assessed when you are doing a barrier analysis. So what are the steps of doing a barrier analysis? Like I said, it is very simple. It is low cost. You don't need a sample size of 900 or maybe 600 to interview 10,000 people to be able to get a statistical difference between the people who practice a behavior and those that do not practice a behavior. You only need to interview 45 people who are accepting to practice a behavior and 45 people who do not practice a behavior. And so when you want, suppose you want to design a barrier analysis study, the first step is to identify the goal, to define the goal, behavior that you want to study, as well as the target group. Because we know you have to be specific really to which target group are you looking at. In the case, for example, of breastfeeding, do you want to look at women or caregivers of children who are 12 to 23 months? If it is COVID-19, are you looking at maybe adults, or you are looking at children or faith leaders or healthcare workers in terms of access to COVID-19 vaccine? So you need to really define what will be the target group. And then the second step is to define the behavior change question that you want to explore in your study. What will be that behavior question that you want to really explore? And from that, you will be able to develop now questions around each of the determinants that you want to study. I've mentioned that it has almost like 13 determinants. So for each of those determinants, you develop open-ended as well as closed-ended questions. Then you mobilize your data collectors, train them on the data collection tool. You finalize your sampling and release them to go out in the field and interview 45 acceptors and 45 non-acceptors, or those people who are doing a behavior and those that are not likely to do a particular behavior. After you've collected the data, or in the process of collecting the data, you need to work out and develop your analysis worksheets. And barrier analysis uses quite an easy to use analysis worksheets in MS Excel. You don't have to have skills really in statistical packages like Stata or SPSS or R to be able to do that kind of analysis. And it is often done together with your data collectors. You bring them together and you input the data that they got from the field into the analysis worksheets. And from those analysis worksheets, it will be able to generate for you the findings, the B values, and associations for that particular behavior. For example, if it is vaccine acceptance. And then after that, you will package or identify those determinants that have high influence or that are statistically significant to be able to influence a particular behavior, and then now use those determinants to be able to use or to develop your messages, communication strategy, as well as the activities that you are going to do. In Sierra Leone, we have used this barrier analysis study tool to identify barriers to uptake of vaccines. And I believe I will have a chance to share that particular study. Thank you so much. Over to you, Paul.
Thank you. Very interesting and looks like a powerful tool. We look forward to hearing a bit more about that. I do want to check with Sophia. Nthenda is our next speaker. Let's check to see, Sophia, if we're double check to see whether we're going to be able to hear you. Yes, I believe we hear you now. Yes.
Hello? Hello?
We hear you.
Okay.
Very good. So Sophia, we know that you all have used this mind and heart dialogue approach. And I wonder if you would explain what this approach is like. What is this about, and how does it apply to trying to encourage people in better health-seeking behaviors?
Thank you so much. I'm Sophia Nthenda from Malawi, and I work with Public Affairs Committee. Mind-heart dialogue, it's an approach that we use in addressing issues. It uses experiential learning methods to invite faith actors into creation space using social behavior change. When we are using this tool, it influences positive change for children, families, and communities. It also enables fulfillment of one's mandate to reach out and protect vulnerable groups. It also empowers the co-creation of positive change. When we're using this, it also creates space for collaboration based on shared experiences, learnings, and feedback from the group that you are working with. It also engages faith leaders to transform. We move beyond messaging and information sharing. When we're using this tool, you adapt gatherings and rituals to increase safety and also reduce the spread of COVID-19. As we internalize the tool itself, we change some of the behaviors that people have on certain issues. It helps to identify ways to strengthen spiritual, emotional support in our communities. During COVID-19 services, people imagine that people stopped praying. They were just living. And the preachers felt hard all of a sudden to stop preaching and looking at the people who were dying. They even didn't have enough information on COVID-19. So let's look at the stakeholder mapping that was there. Please, can you go back to stakeholder mapping? The stakeholder mapping that is there, it is indicating that an exercise that you are giving, you have a flip chart that some people are touching. The objective of that is to map out all stakeholders who have influence on or within the community. So on that paper, you write the last change that you want the people to experience. So what you do is you ask the group whether they have the power to support that change. If they have the power to support that change, they will write something. That's the pink papers that they have put on their heads. And then when you ask a question, and they know that they have the capacity to change, they will go and lift that paper, the last chain that is there. And when they feel it's not a direct change that they can give to the last resolution, they will touch the shoulder of the person who has touched the paper itself. So it goes around like that. And in so doing, you now realize that the change that can be done by either me or a friend at a distance. So that's how you use that. Thank you. And then we can go to the mind-heart dialogue. Good. So during the COVID-19 pandemic, there was that surges of messages, means of health messages on the vaccines, the health rules were not accepted by some religious institutions and some traditional beliefs. So the faith and positive change for children and communities applied to end the misinformation and the discrimination that was there and instill hope in the people. So it adapted how we gather information, how we pray, and how we practice the rituals. Some of the misinformation that were there was that people would say, COVID-19 cannot attack youth and children, but the aged, because of the way the people of 60 years old were dying, but the young people were not dying. So that's why they had that message. And they were also saying, if you walk into a place where there was an infected person, immediately you are going to contract the virus. And they would also say, friends from who comes and jokes about the virus, they don't love you. And they also said drunkards cannot get the virus because the virus will die immediately with the spirits. And others were saying, no, this is not for Black people. Black people are very strong. They have a pigment that the virus cannot survive. Others would say, Black people work very hard in the fields and their bodies are very strong, so they cannot die with the virus. But others were using the word 666 from the Bible to say this virus is the 666 that was mentioned in the Bible. So it brought in some misinformation and some stigma. So the use of the mind-heart dialogue, where you have the mind, you look at the facts that you have, the science, the analysis, you analyze on that one, the reasons that are given, the research that you can do, the experts and technical knowledge deals with the mind that you have. And then you look at the faith. And then you say, in the faith, what is it that we have? The faith that we have is that we have the rituals, we have the beliefs, we pray, we have the motivation to do something, we have the values, and also the religious teachings that we are given by the scriptures. While in the heart, you keep some, you have hopes and fears, you have the experiences, you have the memories, you have the compassion, emotions, and the culture, and the stories that we have. All these, when you put them together in the mind-heart dialogue, you can work better and then adapt how we gather information and praying and also practice rituals. So in our contribution to this mind-heart dialogue tool is that it brings you closer to the issue and also closer to the experiences that you have, and also think of how you can change. So in the use of mind-heart dialogue, it means you as a person, when you analyze the issues, you can be able to change your behavior. So you explore the faith, the convictions, the learnings, and the process. It helps you to grow and also to change the behavior on your own, apart from waiting for someone to change the behavior for you. So thank you so much. That's what we have.
Thank you, Sophia. That sounds like a very powerful method for engaging people with the issues and drawing out their beliefs, and also helping them understand what they are able to change, what's in their power to change. And there's some very interesting overlaps with the barrier analysis in terms of bringing people, engaging people from the community in order to find out what's going on with them, what are their thoughts. I was going to circle back now to Mark and maybe have all our panelists available. But Mark, would you tell us more? I believe you were hinting that you could share with us how barrier analysis was put to use during the COVID pandemic, and give us a little more insight into just how the tool was used and with what results and with what learnings.
Yeah, thank you so much, Paul. World Vision used the barrier analysis tool in almost over 10 countries during the COVID-19 pandemic. And specifically in Sierra Leone, we used this particular tool to understand why people, or the determinants of accessing the COVID-19 vaccine. So we wanted to understand what are the factors that are making people, determinants that are making people to access the vaccine or not to access the vaccine, so that we can be able to design a behavior change strategy and tools, that activities that will help us to address those barriers and to reinforce those determinants that are enabling or enablers to people taking that particular vaccine. So in the case of Sierra Leone, we did a barrier analysis looking at adults who are 40 years and above. And we also had another barrier analysis looking at the healthcare workers. So it was 2 in number. And the reason why we looked at the target group 40 years and above was because at the onset or at the start of the COVID-19 vaccine program in Sierra Leone, the government policy was to give it to people who are 40 years and above. And so we did this study in the 4 regions in Sierra Leone, the north, western, eastern, as well as in the southern part of the country. And why did we do that? It is because we know that determinants which are affecting people's uptake of a particular behavior in one place may not be the same as determinants in another locality. And that is why we expanded the scope to be able to identify and really get information that will help us to design targeted information that is specific to a particular region. So after we did our analysis, we identified those determinants that had high statistical significance between the doers and non-doers of a particular behavior. One, for example, was the social perceived social norms, or people approving, people close to a person approving of them taking a particular or taking the vaccine. Another one was perceived divine will, that people were saying in the north, especially in the northern part of the country, that I can take the vaccine. I think that my faith leader will approve of me taking that particular vaccine. In the southern part, some were saying, no, I think my faith leader will not approve of me taking this particular vaccine. In some localities, for example, the island areas of Sierra Leone, access was a major determinant, because people are saying, I can take the vaccine, but is it accessible? It is not available here at the island. And so as an organization, after identifying those significant determinants, we actually engaged stakeholders to disseminate the findings. And then after that, our health technical program manager, who is a member of the Social Behavior Change Technical Working Group, presented the findings to that technical working group, and they were used to develop messages that will be able to convince people to take COVID-19 vaccine. Some of the interventions, again, that we did was to work with in the Religious Council of Sierra Leone, especially in the southern part of the country, so that they can convince people to take the vaccine. to address those barriers that people are saying, I believe my faith leader will not allow me to take that particular vaccine. We also had developed communication materials that were done by the technical working group members. Like, for example, the posters, we shared those materials, and through our social mobilizers in the field, who worked very closely together with the vaccination teams to encourage people to come and take up the vaccine. We also had, for example, going to the radio, having those prominent people within the community that are influencers or opinion leaders, to go to the radio, to go to the television and speak to people that it is safe to take this particular vaccine, as well as even taking that vaccine in the public. In the northern part of the country, we worked with the traditional leaders who are identified as important people who will influence people taking the vaccine or not. And these traditional leaders engaged people, their citizens, and convinced them that, yes, it is safe to take this vaccine. I approve of taking this vaccine. And so people are more convinced to come out and say, because our traditional leader has taken this vaccine, then even me, I'm coming out and I will take this particular vaccine. We also advocated for the decentralization of the vaccination centers. Like, for example, initially at the start of the vaccination program by the government, it was majorly in big towns and not accessible to those people in remote communities. It was not accessible to people in the highland. And so what we did was to work with the government as an organization to see that those vaccines are actually transported to those localities where people identified access as a barrier to taking those COVID-19 vaccines. And I can say confidently that it contributed a lot in terms of convincing people to take the vaccine, especially in those areas that were hotspots. Because of the perceived severity, people knew that there is a likelihood of me getting this disease. So I will come out and take the vaccine. In summary, we were able to make more informed programming in terms of identifying the messages, the activities that we did to be able to promote the uptake of that particular behavior. There are resources that World Vision has on barrier analysis. I've seen Sony has also dropped in the question and answer link. We can share out these resources so that each of us can be able to have this simple tool, and that is really low cost, to use it in any public health emergencies to improve on messaging. Thank you so much, Paul.
Thanks, Mark. I'm particularly struck by the way that you all were able to use this approach to identify barriers that may vary from one region to another, different circumstances, different populations. It means that you're not just putting out all messages to all people, but clearly you were able to target specific messages in different aspects of the population, focusing on the things that maybe were holding people back and engaging faith leaders, for example, in helping encourage people so that their concern over how their faith leaders would feel about them getting the vaccine wasn't a hindrance to them, to the uptake. So thank you for that. Catherine, I'd like to come back to you now. You indicated that there were some specific resources that SIL developed during the pandemic. Could you share with us more about what SIL was able to do during the pandemic?
Yes, great. And Alexandra has put a slide on the screen. And this slide, hopefully a colleague is going to put in a link to the SIL website, and that will go in the Q&A. SIL created a number of resources, and I want to highlight 3 of them at this point. During the pandemic, as the pandemic developed, as I said, we realized that our research estimated that about 30% of the world's population probably did not have access to basic health information in their local languages. And it was very, very clear that SIL alone was not going to be able to respond to this situation. So SIL partnered with local and global organizations and local language leaders to create relevant materials. But there was so much that was being developed. And one of the things that SIL International, working with SIL Lead, did was to actively compile an extensive index of COVID-19 related health and COVID-19 prevention resources. And I think this was a very helpful resource, not just for SIL, but for the global community in identifying clear, accurate, natural, and acceptable resources that would respond to the needs of local language communities. And I think as we think about be it resilience, and as I think about responding to the next pandemic that we can probably expect, we need to move into this collaborative mode of sharing information and sharing information that's developed in the most appropriate languages for those who are the most marginalized. The second resource that I would like to share is on the screen. You can see something that is called Tips for Translators. And if you were to access that on the link that my colleague Steve Wilston has dropped into the chat, you will see that these Tips for Translators is a resource especially designed for those who were tasked with producing informational materials in local languages, but needed the specific and appropriate health information that to make complex terminology easier to understand and translate. And SIL International brings some expertise in translation services and in translation. And so this was a resource we developed that has been widely appreciated and that was used both by SIL staff and by staff of other organizations. And finally, I would like to highlight the, on your screen, Bloom books, and particularly sign language books. And if either Steve or Lois are able to drop the link for the Bloom library into the Q&A, that would be helpful to people, I think. One of the beauties of the Bloom platform is the integration with video material that can create materials for the more than 150 sign languages in the world. It is possible to record and embed sign language videos alongside images and text, and so that both hearing and deaf members of families and communities can access appropriate materials, in this case for COVID-19 materials. But on your screen you can see books that have been developed here, particularly in the languages of Guatemala and the languages of Honduras. But we were very aware that those who use sign languages, the deaf, were not receiving the information that they urgently needed in order to respond to the pandemic. And so the development of sign language materials in video form and in replicable form, materials that could be adapted and localized for different communities could be available. So hopefully that will be helpful to you. And if you were to go to the SIL.org COVID-19 page, there is a contact email address that if anyone has any further questions about these resources and this information that we've shared, you can use that. So thanks very much, Paul.
Thanks, Catherine. I think it's really interesting what you're sharing about sign languages, because we understand from the dynamics of deaf communities that they often are wary of information that comes from outside of their communities, and have much more confidence in what they hear from one another. So the fact that deaf people were able to create their own resources and communicate them in their sign languages is, I'm sure, was a very powerful tool in engaging those communities.
Thank you.
Yeah. Sophia, I'd like to come back to you again. And one can imagine the tools that you're talking about maybe working within a specific faith community, but what similarities, as you've worked with different faith communities, have you seen across them when it comes to kind of communications and the dynamics of working with them? Are they quite different? Are they similar? What have you seen? Sophia, you'll need, yeah, we go.
Yes, hello?
Yes,
Hello?
thank you. Go ahead.
Yeah, there were some similarities because when we are looking at religious leaders in the country, in Malawi, we have different religions, yes, but we have communities whereby different religions, or in a family, we can have 2 or 3 people separate from their own religion, which means whatever is explained to in another religion, they can discuss together. But we have other religions that do not want their followers to go and to go to the hospitals, even take any medicine. So that's the difference of the religions that we have. But otherwise, most of the religions that we have worked with, it's a similar information because most of them, they use the Bible. The Muslims, they use the Quran and the Hadith, of which some stories from the Bible, they are also used as examples when they are preaching to their congregants. So there are more similarities than differences, except on only those religions that do not believe in going to the hospital, in taking any medicine. Yes.
Okay, thank you. Well, we've been able to hear from the different presenters, and it's time for us to look to see what questions you may have that you would like to ask. And I know some of you have already posted some questions. So if having heard the various presentations, we're ready to find out what you would like to know more about. And so I'm going to go first to the Q&A and see what we're finding there. And see what we can get from our different presenters. So all the panelists should unmute, and if you're using your camera, turn that on. And the first question I see here, Mark, is to you. When one is confronted by skepticism related to transparency, what is the best practice to provide reassurances that the information is truthful in terms of, say, benefits of vaccinations and so forth? Mark, can you unmute and speak to that?
Hello?
Yes, go ahead.
Yes, thank you so much, and thank you, William, for that question. That when you are confronted by skepticism and you want to address that skepticism around, for example, the vaccines, what first, after you do your analysis, for example, if you use the barrier analysis method, and you identify that that is indeed one of the barriers, one option is to go back to the people and then try to understand why are they skeptical around that particular behavior, and now try to design now interventions that will be able to address that particular skepticism and communicate the benefits of why somebody should be able to take the vaccine, for example, in our case in Sierra Leone. And that was also quite common because people were saying, I do not believe this vaccine. I think maybe there is something behind this vaccine and something can happen after that. One, we worked with the technical people in the Ministry of Health to be able to communicate to the people through the radio. We had the faith leaders, we had the opinion leaders in those communities. Even the president himself actually took the vaccine in public. And so that, in a way, convinced people to say, yeah, it seems this thing is safe. It can be taken.
Okay, thank you, Mark. Someone else wanted to know if the analysis or what you actually did in Sierra Leone and with barrier analysis and COVID-19, is that written up someplace where people can access that and look in greater detail?
Yes, we can share the reports, the analysis that we did for consumption. Yes.
Good. We're trying to figure out where best to share all these links. We'll make sure they get to you. In relation to someone else is asking, in working with the faith leaders themselves, they may also have their own barriers and beliefs. So are there strategies that you have used to help those faith leaders, to convince them, say, about vaccine acceptance and so forth? What have you done in terms of engaging those faith leaders in terms of their own beliefs and biases? Mark, well, let's hear from you. And then Sophia, also tell us, because you all engage extensively with religious leaders. So
Yeah.
Mark first.
For me, I would recommend doing a barrier analysis specific to faith leaders. If you realize that is a barrier, or there are some determinants around faith leaders, you can do a barrier analysis to have an in-depth information, or to really identify why they don't want to practice a particular behavior. And the strategy that we used in Sierra Leone, even if we did not actually do a barrier analysis for the faith leaders, was to work with the Interreligious Council of Sierra Leone, which is an umbrella organization of all faith leaders here in Sierra Leone. And after the Ministry of Health engaging them together with World Vision, they were convinced, and they were able to convince their members. They cascaded that messaging to their members in different localities. Thank you.
Okay, so it's interesting that you did not only engage faith leaders in terms of strategies and tools, but also as people themselves whose own beliefs and barriers needed to be the subject of examination. Sophia, do you have any other experiences from you all's work about how to convince faith leaders, or how did you engage with the faith leaders themselves and enlist them to help in influencing others in their congregations?
Hello.
Yes.
Yes, we are, as we work with faith leaders, we come across other barriers. So what we do in using the mind-heart dialogue, you engage them, and then as we discuss using the tools that are the examples, they see for themselves that whatever they had as a barrier, they can clear it out. It doesn't mean that you are coming there and then you create out for them, but using the mind-heart dialogue tool, you discuss with them, and then they see for themselves that this barrier, I think we can use it like this. So they create on themselves when using the mind-heart dialogue tool.
Okay. I think what I'm hearing, interested in what you shared, Sophia, is that it's not a matter of people on one side convincing the religious leaders on the other side, but the religious leaders themselves as part of an exploratory process in which they grapple with their own beliefs and concerns, and you engage them as active participants in that exploration, not as just recipients of some types of advocacy. So thank you for that. I'm looking to see, I note that several participants had raised their hands at some point, and I don't know at what point you did that. So if you have a question that you have not put into the Q&A, please do so, so that we can be sure to take that into account. One of the things that has come up in the Q&A, Catherine, is to be able to get the link to the I assume it says SL analysis. I assume that's the sign language, and we'll get that into that for them. I am seeing another question about the barrier analysis. So, Mark, you had talked about choosing 45 people who were in favor of the behavior or engaged with that behavior, and 45 who are predetermined or were not. And the question is, do you find people and engage with them in order to find out whether they are for or against a particular behavior? Or how do you select people to be in each of those two different groups? There must be some process that you run in order to determine that this person was one of this 45 or the other 45. Mark.
Yes, thank you so much. A good question. The logic, what we normally do is to do some screening questions to identify if an individual is a doer or a non-doer of a particular behavior. And so when you are interviewing that person, you will actually administer relevant questions to that person, either as a doer or a non-doer. And you count as you go along interviewing until you realize you are accepted, you are a sample size, which is 45 doers and 45 non-doers. In the case of the faith leaders, in the case of the healthcare workers in Sierra Leone, we used the snowball technique, asking who do you think in your colleagues can take the vaccine, and they would suggest to us that yeah, so and so can take. So we would go to that person and interview and see whether indeed they are acceptors or non-acceptors, and then use the appropriate questions for that particular person.
Okay, so you had kind of a one-on-one process of exploring with different people to find people that, in fact, were favorable to taking a vaccine and others that were not. And then that process enabled you to establish your two groups of 45. Is that correct?
Yes, that is correct. And one thing about barrier analysis, maybe just to add, is that it is based on interviews. It is not based on focus group discussions. So you do not bring all the people into one location and ask them questions.
I see.
You have to interview a person as an individual.
Okay, so that's a good point. This is not like a focus group of people who all come together, but a set of people, each of whom is interviewed with using the tool that you've developed for that particular issue.
That's correct.
Okay, thank you. I'm looking at Q&A. So part of the outcome of several of these processes is to then develop health messages that address the particular barriers or the particular issues within a group of people. So where does testing of those messages fit in? Is there a testing process before you do it more broadly? How do you do that? Either Sophia or Mark, please.
Hello?
Yes.
In our case, we would say testing of it, we haven't done in the whole country. We have just done part of the country. That's Central region where we are. But in other localities, we haven't reached that because we don't have more resources. And it was also a problem to reach out to different areas because of the restrictions of the movement, because due to COVID-19, yeah. But we would urge maybe World Health Organization to support this initiative, because the Mind-Heart Dialogue, it's a tool that needs to go to different religions and regions as well, and also to be internalized. For us as Public Affairs Committee, because we are a partner or a chapter of IRC, we started with what we call Faith and Positive Change for Children, which is a guide, facilitator's guide, and it has the video. We do also in-person trainings and the orientations. And because of that, the messages that are found in those faith and positive change for children guide are also found in mind-heart dialogue as examples. Because when they were developing this faith for positive change for children facilitators guide, it's the virtual trainings that we normally had with IRC. So it has been internalized with the group that has done it and the master trainers that we have. So we expect support to be given to the master trainers to go into the field and then train more religious leaders.
Okay. So what I'm hearing is that as you engage with master trainers and they're engaging with others in that process of engagement, you're actually finding out if people are resonating with the messages that are being developed and shared. So that makes sense. Mark, do you have anything you want to comment in relation to testing of the messages that may come out of the barrier analysis process?
Yes, for our case in Sierra Leone, the messages were developed by the Technical Working Group on Social Behavior Change and Communication. And what they did was to share out the messages after developing them to partners to look at it and give their feedback, and also pre-test in communities to see if they really are effective messages. So yes, it was done by the Technical Working Group.
Okay, thanks, Mark. Catherine, when we see the materials that are on the Bloom Library, for example, we're seeing that final product, but we don't see behind that to know what sort of process was used. So tell us a bit about any testing or that might have been done with some of those materials.
I think that's a great thing. One of the beauties, the Bloom platform, which foundationally is open source and anyone can access it through the links that have been provided, is that the designers and developers of those materials are in the our local community members. And because the materials can be easily printed out as PDF or used as video or e-files, they can be immediately shared with others in the community who use those local languages, and then versioned or edited and adapted. And so continuing versioning, continuing adaptation to meet the needs of the community is easy for local material developers to do. I think it's important to emphasize that SIL is not the one who generally produces materials. It is those who are the speakers of the local languages and those who know and understand the local context the best. We've heard about the barrier analysis, and it strikes me that once an analysis such as this has been done, there will be real awareness of how do we communicate well with local communities, and to then design and develop resources for that community that's well targeted. And because of the simplicity of the Bloom platform, these can be refined as we understand more about the development of materials. In the Q&A, I have dropped in a link. So it's in the Q&A answered section as a response to Dr. Schreeder's question at 1402. I dropped in a video link which describes how deaf communities, primarily in Central America, have designed and developed sign language materials in local languages and how that collaboration happened together. And so if you have an interest in sign languages, and if you have an interest in how collaboration works in a cluster of language communities working together, I'd commend that video to you, because it does talk about how testing and multi-language collaboration works well. And that process would work as well in oral languages and spoken languages as it does in sign languages. The process of clarifying information and ensuring that content is natural and acceptable to the community.
Thank you, Catherine. I had some engagement myself with those communities that speak in the sign languages, and it was fascinating to see how highly collaborative they were. And I think that's a lesson for all of us. The processes we're talking about today are collaborative and engage community. And I think we're seeing that in several different facets. And certainly language is one of those, and the importance of engaging with speakers of the languages in the areas that we're all serving. But also making people part of that process is very important. Yes. It's not about experts pushing out information to passive recipients of that information, but all of the things we're talked about today is very interactive and engaging people in helping shape the messages that will go out to them. We'll be wrapping up pretty soon. I want to check with all three of our speakers, Catherine, Mark, and Sophia, and check to see if there's anything that you would like to share that hasn't gotten out yet. Maybe something that has to do with, based on the experience you've had, what would you recommend going forward for others to appropriate these approaches and utilize them in future situations? Sophia, let me start with you. Do you have anything you would like to share about that?
I would like to share to the communities to look at the tool of mind-heart dialogue.
Okay.
Look at it and then invite the people who know about it for the training. It's a very good tool that it changes the behavior of an individual when you use this tool. It's very effective. Thank you.
So it'd be valuable for people to have a look at the resources on the Mind-Heart Dialogue and give some thought to how they could utilize that process in a future situation in order to draw people in and help them themselves to work through that process of exploration and finding good solutions to health challenges. Catherine, anything that you would have to suggest for us?
I think one of the things that I would say, I just want to respond very briefly to one of the final questions that are on the, that's on the, well, two final questions there. First of all, strategies to engage community influencers, youth and women's groups. Some of the most effective materials that we saw were developed not necessarily by health professionals, but by local language communities, by children, and by, as you say, as the questioner suggests, women's groups and others. We did some informal documentation of the impact of the materials and looked at some of the strategies, particularly for distribution, dissemination of a range of materials. That has not been published, but I'd be happy to interact with the anonymous attendee about that documentation at the email address that we'll share with you. But the participation of a range of community members is so important because each group has a different concern. Parents are concerned about children. Children, we were aware of the issues of fear and anxiety among children. Businessmen and informal, when I mean businessmen, I mean businesses in local communities were concerned about losing their income. People were concerned about livelihood. Materials need to be designed for audience and designed in order to respond to concerns by a range of different people. But, yeah.
Yeah, thanks for that reminder, Catherine. I think all of our panelists today would affirm that the importance of not just looking narrowly or very generically at a community, but engaging different parts of a community to make sure that we are addressing the concerns and issues experienced by them. Mark, any final thoughts from you on the application of your barrier analysis? So somebody's asked if you've ever used it with animal disease emergencies and so forth. So just how else would you recommend going forward that people might take advantage of a barrier analysis tool?
Yes, I'm not aware whether World Vision has used it to do to study behaviors associated with animal diseases. But what I can say is that the barrier analysis tool is quite adaptable. It can be used to study different behaviors. And globally, around 39 organizations have used the barrier analysis tool in over 50 countries to be able to understand behaviors associated in, for example, in water sanitation and hygiene, COVID-19, child survival, food security, and all those sectors. So it can be designed, you can use it, and it is simple. It is simple and it is low cost. You don't have to have a lot of resources to be able to do this. And that is why it is relevant for public health emergencies, so that as you do it within the short time period for you to be able to design the messages, you can be able to mobilize people, have it, and then do targeted messaging. Thank you.
Mm-hmm. Thanks, Mark. I think that's something we're learning from all of our participants, all our panelists today, that the things, the tools and resources they're sharing are used quite locally. So it really is important if we want individuals and groups within societies to change their behavior in any sort of issue in which we're engaged with them. We really have to go where those people are and find out what language they speak. How do they communicate with one another? What are the specific concerns that they and a group they may fit into have? And how do we engage those people as active participants in finding solutions for people having accurate information and applying it to their health concerns? I think we'll probably wrap up there, and I'll turn it back to our hosts for any final comments. I just want to thank again to Catherine, Mark, and Sophia for your time today and your willingness to share with us what you all in your institutions have learned and readiness to serve as a resource for others. So thank you. Alex, back to you.
Thank you so much, Paul. And I'd like to send my thank yous to you, Paul, for great moderation and keeping us on time. Thank you to Catherine and Mark and Sophia. I think as you've all illustrated very well, we have exceptional existing resources that we can repurpose for many different contexts and needs. And that is a big piece of the work with the WHO Faith Network, that we can collaborate and share peer-to-peer and adapt things. So part of this mission for us in this series of webinars, this is the first one, and we will share more information about the following one, which will be in November, around stigma and resources that are associated with that can be shared and used in other emergencies, is that we have such a wealth of knowledge and expertise within the WHO Faith Network and beyond. And it's really about utilizing that first, especially in emergencies and for preparedness. Often it can be very busy and a little bit chaotic in the midst of an emergency. And so part of what we're doing now is looking at what already exists today and how can we reutilize that and learn from each other. So I definitely learned so much from everyone today, especially around the importance of language in a broad sense, not just translating, but making sure it's inclusive, making sure we know how people understand things, as we talked about the barrier analysis, making sure that, as we talked about the mind and heart dialogue, the interactions between faith and the mind and the heart, this is really important to make sure that all aspects of how we understand and how we communicate are addressed for our better health and for making sure that we are cohesive in our response to any emergency in our communities. So I thank everyone for your time today. We will share the slides and the resources with you. If you receive this through the network mailing list or through EPI-WIN, you'll receive that shortly. Some links were put into the chat as well. Apologies, the chat didn't work. We're not sure why, but technology always gets the best of us. So that is why it's valuable, as you've all mentioned, to keep things simple. You all have mentioned that about your resources, and it is a very valid point. So this is live streamed to YouTube, and we will update it on YouTube to include the different links that were shared as well. So there will be a one kind of stop shop there.
Excellent.
So I will give the last word actually to Paul. If you have anything you want to say as the person who did listen and digest all this and is an expert on this topic. So thank you, everyone. Over to Paul for one last word, if you have anything that I missed, and then we can close.
Thank you. It's been a privilege today to be able to just facilitate a conversation. I think an important thing and something I learned through the COVID pandemic, it's not just about big, bold, monolithic messages that just need to be pushed out to everybody. It really is about engaging people and communities and finding out what's on their minds, what's on their hearts, and what may be preventing them from being able to experience better health. And we've seen that today in various ways of how we have to take seriously people and where they live, what they think, how they communicate with one another. And I do know that faith communities and faith-based organizations are incredibly important as a part of that process, because typically such organizations are very embedded in local contexts. And so those of you who are participating today that may be part of faith-based organizations, I just want to urge you to continue that engagement in communities, with the people whose health you're trying to improve, and take advantage of those local roots that you have. And for all of us then to not just develop the broad messages that everybody needs to hear, but really be ready to tailor those messages according to the needs of the people whose lives we're trying to touch, and especially those who are particularly underserved. Many people in society will hear the things on the television, and they'll see it on the internet, and they'll be receiving information in many, many ways. But there are many underserved populations who need the sort of attention that has been described today by our panelists, and so that they aren't left out, and that there aren't unnecessary barriers to them benefiting from the health measures that are available to them. So I think that's my final word, Alex.
As always, very well said. Thank you so much. Thank you to everyone. We will follow up with resources, and the recording is available live already on YouTube. We really appreciate you taking the time to be with us today. To Paul and Catherine, Mark and Sophia, thank you so much for sharing your expertise. And we're looking forward to collaborating further on the next webinar. And of course, always together in this for the better health of all. So thank you so much. Have a great day, everyone. Thank you.
Thank you. Bye, everybody.
Bye.